Welcome back. Well, COVID-19 infections in South Africa continue to soar. The Health Ministry says the country has recorded 2,312 new cases in the last 24 hours. This brings the total number of confirmed cases to 48,285. 46 more people have died. Now, the death toll stands at 998 nationwide. The Health Ministry says 45 of the 46 fatalities came from the Western Cape. Mpumalanga registered its first fatality. This means all 9 provinces have recorded at least one COVID-19 related death. Now, the country's coronavirus recoveries, which is important to note, now stands at 24,364, which translates into a 50.5% recovery rate. All right, so I want to get a sense of where we are in this fight against COVID-19. After 74 days of lockdown in South Africa, where are we in this fight against COVID-19? Let's get some answers. Professor Salim Karim joins us now live. He is the chairperson of the Ministerial Advisory Committee on COVID-19. Professor, a very good morning to you.
Good morning to you, Blaine, and good morning to the listeners.
Flattening the curve. By now, I think the majority of the world's population have heard this term. For those who haven't, well, it's about reducing the rate of new infections so that the peak is lowered to a level where, I guess, hospitals can cope with COVID-19 cases. We know this is not a single event, Professor. It is an ongoing process. Having said that, what would you say to parents who are still very much anxious about sending their children to school when the number of infections is on a rise?
So we're in a very unusual situation in that most countries would ease the lockdown when their cases are actually going down. Yeah. We are in a situation where we are easing the lockdown as our cases are going up. And there's many reasons for that, but principally that we cannot sustain a long-term lockdown because the cases are likely to rise for several more weeks, if not months. So what we have a clearer understanding of now is that children are less susceptible to this virus, and that when they do become ill, they have a milder form of the disease, in fact, often asymptomatic. And we have very few deaths from COVID-19 in children. So the disease is relatively safe in children. We do see some occasional illnesses, but those have been rare and those have generally been mild, and children have recovered from them. So there is no reason at this point not to send children to school. If we look at the overall epidemic, we have a growing epidemic, principally in the Western Cape and to a lesser extent in the Eastern Cape. And we're starting to see cases rise in the rest of the country at a very slow rate. So we're seeing an epidemic that is going to pace itself differently in each of the different provinces. So the Western Cape being about 3 to 4 weeks ahead of the rest of the country. Eastern Cape will follow because of the communication between the East and Western Cape. And then we'll see Gauteng follow, and then some of the other provinces will continue to have outbreaks.
So without natural immunity or a vaccine, almost everyone may be at risk of the coronavirus infections. In terms of weekly trends in testing, Professor, as well as cases, what have you picked up?
Well, I think there's a very nice analysis that was undertaken recently of the first 90 days. And if you compare South Africa with most of the other countries of a similar nature, especially our BRICS countries, you will see what a dramatic difference there is between South Africa and those countries. Within the first 90 days, most of those countries had exponentially growing epidemics, large numbers of deaths, and so on. South Africa, we have managed to keep a lid on the overall epidemic. We have an epidemic that's growing, but is to a much lesser extent than seen elsewhere. And we have a much lower death rate as well. And that's because the health system can cope. As you so eloquently outlined, if we flatten the curve, which we have done successfully so far, where we keep the number of infections at a particularly low rate where our health system can cope, then we will not see as many deaths as you see in the other countries. And we've been coping well in terms of managing that process to date.
Professor, I need you to stand by. We need to say goodbye to our SABC2 viewers. We're going to continue this conversation. I need to borrow a few more minutes of your time, Professor. We need to really get down to the science of COVID-19. By doing that, we're going to give, parents out there make them better equipped in order to make these judgment calls. Thank you very much indeed to our SABC2 viewers. For those who have access to SABC News channel, stick around to get you more news next. All right, Professor Salim Karim is still with us. Professor, thank you very much indeed for sticking around. I just want to talk about these tests that we are doing. I just see now that the tests conducted so far is over 920,000. With regards to the tests that we are currently using, can you fully recover from COVID clinically, but still have detectable virus in you?
So this has been well described. We know that when a person becomes infected with the coronavirus, that for about the first 5 to 7 days or so, we call that the incubation period, they don't have symptoms. But then when they do have symptoms, roughly at about 5 to 7 days after infection, for about 2 weeks thereafter, we will continue to find virus. So the test is positive from about day 3 post-infection to about 14, 21 days. But after about the 8th to 10th day, infectiousness is much lower. By day 14, we know that most people will not be infectious, even if we can identify the virus in their throat. But the virus that we detect is not live. It is bound to antibodies, and it is dead, and it is not infectious.
And I keep on saying that scientists, as well as us, are still learning a lot about this deleterious effects of COVID-19. And I read a report recently saying that staying 6 feet apart in terms of physical distancing might not be enough. And some experts are saying that the world needs to take airborne transmission of the virus seriously. We know that the schools are banking on this 1.5 to 2 meters in terms of physical distancing. Is it enough, Professor?
There are 3 ways in which this virus spreads, and we have a reasonable understanding of all 3. The first is from direct exposure to little droplets. So when you speak, when you breathe, when you cough, you put out these little droplets, and they are teeming with virus. And if you get direct exposure to those droplets, you can become infected. The second is through an indirect method where these droplets contaminate a surface, particularly in things like metals, where the virus survives for a long time. You then go and touch a contaminated surface with your hands, and you put your hands on your nose or your mouth. You then spread the virus in that way. And then there's a third way, which is airborne transmission. And there we see that you can create aerosols, and so this virus can become airborne. The relative importance of each of those 3 has been changing over time. So right now, we think that all 3 are important, but airborne transmission much less so. And that's based on household contact studies, where people have lived in very close proximity and have still not become exposed to the virus. So we think principally it occurs by proximity, in other words, direct spread. So keeping a meter distance is a pretty good way to go. Ideally, 1.5 meters, but even a meter is a good way, is a good compromise. Then to undertake, to look at the other forms of transmission, we look at regular cleaning of surfaces, ensuring that you wear a mask and that you don't contaminate surfaces if you have the virus. So our current strategies are pretty well designed to reduce our risk from all three modes of transmission.
Right. I want to talk, Professor, about the race for a vaccine. The top doc in the United States, Dr. Anthony Fauci, I was listening to him the other day saying that they are going to start manufacturing doses of the vaccine way before they even know, whether it works, and they might know if it is efficacious or not, maybe by November, December. So basically, starting to manufacture while still doing research. In your opinion, is that a good route to take?
Well, everything we normally do with vaccines is out the window as far as COVID is concerned. When you do vaccine research, it takes many years. Just think about it. We are about 40 years into the HIV epidemic. We don't have a vaccine. It took years to get, hepatitis B vaccine or measles vaccine. So vaccines are not quick solutions. In COVID, we have changed the playing field. And in COVID, we've got several different candidates that have been developed. There's about 14, 15 trials, even more now, underway in humans. And we will likely see the first sets of results coming out. So 2 of the trials have already released results, and we're going to see others. What is at issue is that we have to ensure that these vaccines are immunogenic. In other words, they generate the immune response and the antibodies that will protect against the virus. But even if we know that, we still don't know if it actually works. So we have to do studies in humans, and those are large studies. There will be, in the tens of thousands, if not hundreds of thousands of people in order to assess whether they work. Because you'll have to vaccinate half the people with the real vaccine, the other half with a placebo, and then you look at the rates of the disease in the 2 groups. Now, that takes a long time. And if we go that route, we can expect that we won't have a vaccine anytime soon, probably late next year. So there's now much discussion about whether we should just do human challenge studies, and that's a complicated debate being undertaken by the World Health Organization. But to undertake these trials and then wait to the end of those results before you manufacture, that's another year to a year and a half. So to concertina these different timelines, people are at risk developing the capacity to manufacture while we look for whether it's effective or not.
Right. I just want to go back to testing. Is it true that if you take a test and you wait after 5 days or so, does that make it null and void by holding it for 5 days?
So the big issue with the lack of tests that we have right now, we have a real problem, and it's a problem that we are trying to buy the same tests that the rest of the world is trying to buy. And so there's a global shortage of these tests, and we need to find different ways in which to get these tests. And I was just talking yesterday to the head of the Africa CDC, and he was just briefing me on their latest acquisition. They are now getting 15 million tests a month for the next 6 months that they have secured. Yeah. And South Africa will get a share of those. So we'll address our backlog. But the problem with the backlog is the turnaround time, that as soon as you start delaying it, for clinical patients, it becomes critical, because for a patient to be cared for, we need to know whether the patient's got COVID or not. For a person in the community that we are testing for control purposes, it's not as critical. And the reason for that is that as soon as we take a swab from somebody, we call that person a person under investigation, a POI. Right. The moment we do that, they are supposed to self-quarantine, because anyway, even when we have the test, it still takes 2 to 3 days to get a result.
Yes.
Now it's taking more, 5, 7 days. So you have to self-quarantine. If you don't get a result, you should just self-quarantine anyway for 14 days, Professor, and then de-quarantine at that point.
We thank you very much indeed for your time. Unfortunately, we got to go to another breaking news story, but we thank you very much indeed. Our mission here is to give our viewers the facts to help them make their judgment on how to protect themselves as well as their families. And we thank you very much for you as well as the family of scientists in helping us do that. God bless, be well.